Repair of cardiac wound, without bypass. With cardiopulmonary bypass, the physician gains access to the heart using an incision through the sternum, median sternotomy, or the left anterior chest wall, thoracotomy. A pericardial window may be created if the diagnosis of penetrating cardiac trauma is not confirmed. Once penetrating trauma has been confirmed, the pericardial sac is incised and clotted blood and fluid removed. The entire heart is inspected and wound site, S, identified. Small lacerations are repaired with sutures and reinforced with Teflon felt pledges to anchor the sutures. Lacerations to small coronary vessels are ligated. Lacerations to larger coronary vessels are repaired. Large myocardial wounds may require synthetic grafting to cover the wound. The surgical incision is closed. Chest tubes and/or a mediastinal drainage tube may be left in place following the procedure. Suture repair of aorta or great vessels, without shunt or cardiopulmonary bypass. With shunt bypass. With cardiopulmonary bypass. The physician gains access to the mediastinum through an incision through the sternum, median sternotomy, or the chest wall, lateral thoracotomy. The physician repairs the aorta or great vessels while the heart is still beating. The physician closes the surgical incisions and dresses the sternal or chest wall wound. Transcatheter mitral valve repair, percutaneous approach, including transseptal puncture when performed, initial prosthesis. Additional prosthesis, ES, during same session. The left chest is opened. The pericardium is opened. A gloved finger is used to invert the left atrial appendage into the left atrium. The finger is placed across the mitral valve. Blunt tearing is used to open the areas between the leaflets, which have been obliterated by scar tissue and inflammation. The finger is removed and the chest is closed.